Dr. Sanjay Valavinayaka. I'm a senior registrar in obstetrics and gynecology, and currently I'm working at Teaching Hospital on Radhapura. So first of all, I would like to thank the organizing committee for the invitation you've given me to participate in this forum and present with my abstract. So I'm going to talk about benign metastasizing leiomyoma, which is a very rare condition in reproductive age women. So this is one of a case which I personally came across during my postgraduate training period. So during my presentation, I would like to talk with you regarding benign recognition of benign metastasizing leiomyoma. In short form, we are calling BML, and the common sites which we can see this and the way they present with, and what are the investigations we can do to diagnose this condition and the available management options. So let me introduce my patient. She's 36-year-old, unmarried, nulliparous lady. She presented to us with progressive abdominal distension for 1 year duration. She had regular menstrual cycle without any heavy menstrual bleeding. On examination, it revealed that she's having a 34-week size fibroid uterus. And after our examination, we moved up with the investigation with ultrasound scan of the abdomen, which confirmed our clinical finding. Then, after careful counseling and everything, she opted to undergo open myomectomy. So there, we removed multiple fibroids from her uterus as well as from her both broad ligaments. These broad ligaments fibroid have special features. Those were not connected with the uterus. So after that, excuse me, sorry for disturbing you. Can you, and we closed up the surgical site, and after the recovery of this anesthesia, we counseled regarding the findings during our hysterectomy. Thereafter, her counseling, she agreed to undergo reopening and remove the whole uterus, including all the fibroids, even though she's having further wishes in future, but she want to recover from her suffering because she had suffered a lot due to these multiple fibroids and the pain and exposing to multiple surgeries. We counseled her regarding the possible outcomes during the surgery. Finally, she opted to have hysterectomy and bilateral salpingoprectomy because we explained her that there is a possibility that these fibroids are due to benign metastasizing leiomyoma, which can reoccur if we leave her ovaries inside. So, and we also discuss the possible other management options like medical menopause. That means giving GnRH analog to her, but still she wants to undergo total pelvic clearance because she doesn't need to suffer anymore. Finally, she undergone reopening again 1 day after the initial surgery, and we removed all the deeply seated pelvic fibroids, and at the same time we removed her uterus, cervix, and bilateral tubes and bilateral ovaries. And she had uneventful recovery, and she was started on estrogen only hormone replacement therapy as she is very young. That means she's 36-year-old, and as she needs continuous estrogen supply to maintain her normal health, we started her on estrogen only hormone replacement therapy. We didn't include progestrogens because she doesn't have her uterus anymore. So this is the patient I came across, and this is the intraoperative view of the initial surgery when she presented to us with a 34-week size fibroid uterus. And I think you can see this is one of the large broad ligament fibroid she had, and this is the ovary. This is the posterior view of the uterus. And initial surgery, we entered into her tummy with a low transverse incision. Right. So I'll move on to my main topic, the benign metastasizing leiomyoma. As I mentioned you earlier, this is a rare condition which we can see in reproductive age women. This demonstrates a non-malignant metastatic phenomenon usually seen after uterine leiomyomas. The special thing is this display unusual growth pattern with extrauterine appearing smooth muscle tumors. That means most of the cases, these metastasized leiomyomas, that means in simple terms fibroids, we can see without any connection to the uterus. In our case, those fibroids were in the broad ligament without any connection with the uterus. The interesting thing is the mean age of the patient during the initial surgery is 38 years. And this condition is characterized by history with low mitotic indices and absence of nuclear pleomorphism and without any evidence of invasion. Same time, they don't show any atypical nuclear formation in histology, and same time they don't show any coagulative necrosis, and they don't show any pseudocyst formation during the histological assessment. And if you go to the immunohistochemistry of this patient, those immunohistochemistry studies shows that these tissues have estrogen receptors, progesterone receptors, as well as luteinizing hormone, that means LH hormone receptors. So I'll move to my next subtopic, the common sites these fibroids metastasize. Even though they are not malignant, they can spread almost all over the body. Commonest site is lungs, even though we didn't see that in our patient. Other than that, this can be seen in deep pelvic cavity, retroperitoneal space, even in heart, inferior vena cava, retroperitoneal lymph nodes, muscular tissues of the limbs, skull, as well as in the breast. So, how does this happen? So, there are theories to explain how these fibroids metastasize to the other sites other than the uterus. So, the theories we use to describe the pathophysiology of endometriosis is applied to this as well. Those are, one thing is coelomic metaplasia. There, these subcoelomic mesenchymal cells transform into myofibroblasts under the influence of estrogen. That is the reason where this gives rise to multiple broad ligament fibroids. And another theory which describes this BML is hematogenous as well as lymphatic spread of the myofibroblasts. This is easily described the appearance of fibroids outside the peritoneal cavity, like lungs, skull, breast, brain, and other muscle tissues, those things. And same time, most of these cases were observed usually following a surgery to a fibroid uterus, either by open hysterectomy, or else laparoscopic hysterectomy, or else a vaginal hysterectomy. So this shows the theory of seeding through the peritoneal cavity. That means during the surgery, without our awareness, we deposit multiple tissue particles inside the peritoneal cavity, which gives rise to secondary origins of the fibroids inside the peritoneal cavity. So the presentation of these patients are depend on the site they are having. As I said earlier, these are not malignant. This is not malignant condition, but still they show local invasion, and this gives rise to symptoms of space occupying lesion. So the symptoms will depend on the site where they appear. As investigations, the most commonly used investigation to diagnose this condition is ultrasound scan of the abdomen and pelvis, which is easily available, and with very low cost we can use it. And same time, MRI scan, that means magnetic resonance imaging, is a very good investigation to confirm our diagnosis, because the soft tissue imaging is excellent in MRI scan. As I told you earlier, the commonest place which this condition appear is lung. So chest X-ray and high-resolution CT scan will help to detect these lung mets. So management. This is one of the most difficult part of this condition, because, as I said you earlier, this condition usually seen in reproductive age women, and same time very difficult to control, because number one, there is no standard treatment method to this condition, unfortunately, because the number of cases we have observed through so far during past many years, and during the literature survey, the number of cases are very, very few and very, very minimum. So there is no any standard well-organized treatment method, but the treatment method depends on the site of the lesion, size of the lesion, and the symptoms which she is having, and the age and the fertility wishes that patient's having. So possible management options are, one thing is local excision, another one is ovarian suppression, because as I said you, these tumors having estrogen receptors and progesterone receptors. So if we can remove the endogenous origin of estrogen and progesterone, theoretically, yes, we can suppress this disease. But the problem is this suppression will affect the patient's life, because as she may have fertility wishes, she may in her younger age, which she need estrogen and progesterone for her daily life. So same time, if she has completed the family, and if she is not having any more fertility wishes, and if she is close to her usual menopause age of that population, so what we can use is we can do a total abdominal hysterectomy plus all the other fibroids removal plus oophorectomy, which will put her into a menopausal state where she is lacking of her reproductive hormones. And same times, the new development, MRI guided focus ultrasonography. In Sri Lanka, we don't have this facility. And same time, the radiological management, like radiological guided feeding vessel embolization, which we can try. But the thing is, unfortunately, these things are not available in the literature, because the number of cases in this category is very minimum. In our case, as she is 36-year-old, and as she underwent total abdominal hysterectomy and bilateral salpingo-oophorectomy, and she needs estrogen for her rest of the life until she reach to her natural menopausal age, we started her on estrogen only HRT. But still, theoretically, there is a possibility that this condition may reappear again, because we are giving exogenous estrogen. But fortunately, our patient still not having any kind of symptoms which suggestive of reappearance of these benign metastasizing leiomyomas, and she's under the continuous surveillance of ultrasound scans, and still she's doing well following her surgeries, and she's not having any more symptoms following the surgery, and she's doing well without any postmenopausal symptoms due to our hormone replacement therapy. But still we don't know when she present again with the similar condition. And I would like to tell you another thing. There are cases in the literature which shows that this condition has observed in people who have menopause and who are not on HRT. That is something weird. because in a menopausal lady who is not on any kind of hormone replacement therapy, doesn't have this estrogen and progesterone, but still there is a possibility that this condition reappear again. So this is the condition I want to discuss with you, and I'm really happy to answer any questions if you are having. So thank you very much.
Thank you, Doctor. That was an excellent presentation. Hope the participants have learned and benefited by sharing your research work. Now it's a Q&A session. Kindly feel free to ask your questions to Dr. Sanjaya. Anybody? Yeah, thank you, Doctor.
Okay, thank you very much. And I would like to thank the organizing committee of this conference to give me this chance to present my abstract. And thank you all of you. And as Sri Lankans, we are in a very crucial state.
I'm Ida Abbasi, a fourth year student of medical virology at Tehran University of Medical Sciences. Do you have my voice? The seminar that I'm presenting to you excuse me.
Yeah, Doctor, we can hear you. Yeah.
Can I continue?
Yes, you will continue.
Okay, I'm Ida Abbasi, a fourth year student of medical virology at Tehran University of Medical Sciences. Now, the seminar that I'm presenting to you is titled Molecular Diagnosis of Varicella-zoster Virus and Expression of microRNA 122 in brain cancer tissue samples. In the introduction section, I give brief explanation about central nervous system cancer, varicella-zoster virus, and microRNA 122. Then I present different parts of the study. Tumor of the central nervous system induce all tumors that form inside the skull and spinal cord. These tumors are divided into two general categories, glioma and non-gliomas. In terms of prevalence, 2% of all cancers belong to the CNS, which occur all any age, but it's more common in the elderly and is more common in men than women. The prevalence of this type of cancer is relatively low compared to other cancers, but it's among the top 10 cancers in terms of mortality rate and in malignant. Even with treatment such as surgery and chemotherapy, the patient's survival is about 1 year, about just 1 year. The cause of the disease isn't exactly known, but various risk factors have been studied that can be effective in the development of the disease. One of these risk factors is the infectious agent, including viruses, which can play a role in the development of cancer. Viral infections are responsible for approximately 10% of all cancer worldwide. To date, 7 viruses have been proven to be oncogenic, including papillomaviruses, EBV, and HHV-8. The common feature of which is that cancer develops after chronic infection. The virus that we explained in the study is varicella-zoster virus. This virus belongs to the herpes family and is one of the alpha herpes viruses. In terms of structure, like other herpes viruses, they have an envelope. Their capsid is icosahedral, and they have a tegument. Their genome is linear double-stranded, about 125 base pair. VZV or varicella-zoster virus has a very high prevalence around the world, so that more than 95% of people over 15 years of age have antibodies against VZV. This virus is the cause of primarily infections of chickenpox and secondary infection of shingles. In childhood, it enters the body through breathing and contact, multiplies in the lymph nodes, enters the blood through T lymphocyte, and cause a systemic infections. Since this virus is dermotropies, it has a lytic cycle in skin cells and causes skin lesions in whole body. Like other herpes viruses, VZV becomes latent, and its hiding place in the posterior root ganglion and remains there for the rest of person's life. In the 10 to 20% of adults, the virus becomes reactive due to various factors such as a weak immune system, damage to nerves, or the use of certain drugs, and leads to shingles, which is much more severe. This reactivated virus goes to various tissues. The most common tissues it infects is CNS. The reason why we studied this virus is that this virus is neurotropic and indirectly involved in tumorigenesis through the synthesis of apoptosis inhibiting proteins ORF63, which cause cell immortalization. In this study, our target gene to detect the virus is the same ORF63 because of its importance role in carcinogenesis. Another factor that we investigated in this study is expression level of microRNA 122 in cancer cells. In all microRNAs, small RNAs are 80 to 22 nucleotides in size, which are non-coding, and their role is to regulate gene expression. These are effective in many cellular processes such as proliferation, differentiation, and apoptosis. Different types of RNAs have been identified. Each of which has different functions. For example, some microRNAs are oncogenesis and cause cancer to progress, but other are tumor suppressors, such as microRNA 122, which plays a tumor suppressor role in breast cancer. Well, our goals of this study are the molecular detection of VZV in CNS tumor tissue samples and also the expression level of microRNA 122 in these cells, which investigated. In this study, 58 fresh CNS tumor biopsy materials and adjacent non-tumor tissue of CNS tumor as a control. About the results, the demographic information of the samples was as follows. We had 58 samples that include 17 types of tumors, including schwannoma, meningioma, and glioblastoma. 52% of the samples were female patients and 48% were male patients. Out of 58 samples, we had 6 samples, about 10% were VZV positive. The expression of microRNA 122 in tumor samples compared to the healthy samples had a decrease in expression, which was statistically significant. Also, the expression of microRNA 122 in VZV positive tumor samples were significantly decreased compared to VZV negative samples. Then for discussion. Because some of the studies conclude the VZV can be effective in the development of malignancy, and another group of studies showed that microRNA 122 has the role of a tumor suppressor in some cancers. And when cancer develop, these are down regulated in the serum. They are about tumor suppressor. Then, on other hand, we know that viruses, when they infect the cell, affect various cell factors to change the condition in their favor and reproduce. And one of these factors is microRNA. From the result of our study, it can be concluded that this decrease in microRNA expression may have been affected by the virus. And the virus has caused cancer by reducing tumor suppression. Of course, this is only a hypothesis and need future research studies should be designed to measure the effect of VZV on microRNA in vivo and in vitro. Thank you for your attention.
Thank you, Dr. I.
Self-examination practice among secondary school female teachers. So here I wanted to emphasize on that. Do you know only about 1 in 10 secondary school female teachers practice regularly their breast self-examinations, and also there are only about 1 in 3 of these secondary school female teachers were knowledgeable about breast self-examination. That is really amazing figures. That is why I want to start my presentation from here. As you mentioned, the title is about the breast self-examination practice and associated factors among secondary school teachers in southern Ethiopia. When I see some literatures shows that these days an estimated 1.7 million women are diagnosed with breast cancer, and about 522,000 women die from the breast cancer globally, and it has been predicted that the worldwide incidence of female breast cancer will reach approximately 3.2 million new cases per year by 2050. And however, the higher burden of this cancer was observed in less developed regions of the world, and which accounts for 6% of new cancer cases and 63% of cancer deaths worldwide. In sub-Saharan Africa, it's estimated that the prevalence of breast cancer women aged 15 and above was 23.5 per 100,000 women, and an estimated 35,427 women died from breast cancer with a crude mortality rate of 12.8. So while high proportion of cancer are diagnosed at an early stage in high-income countries, they are diagnosed at more advanced and often fatal stages in developing countries. However, in Ethiopia, breast cancer screening practice among women was only 6.9%. That's really very small amount, and it is the screening level is very low. As the majority of the Ethiopian populations reside in the rural areas, where there is no access to health facility equipped in mammographies, breast self-examination practice will be the best approach for effective prevention of breast cancer and its complications. Hence, the purpose of this study is that to assess the magnitude of the breast self-examination practice and associated factors among female secondary school teachers in Gammo Gofa Zone of the southern Ethiopia. The method is we conducted a cross-sectional study, institutional based at a school level. So it is far from the center of Ethiopia, the capital city of Ethiopia, that is Addis Ababa. It's around 502 kilometers. So it is one of the rural areas, and the study area has a total population of about 1.5 million. And the study was conducted in this zone in 2018. And this study population, we used this estimation of the sample size using the EpiInfo, and we got around 247 women school teachers to be included, including the response rate. We used random selection to get representative sampling, and we used the self-administered questionnaires. When we see the measurements we used in this study there are a total of 34 questions was used to assess the perceptions of these female teachers toward these breast self-examination practices. There is 5-point Likert scale responses, with choices ranges from strongly disagree to strongly agree. And based on these scales, to assess susceptibility to breast cancer, seriousness of the breast cancer, and the benefits of the breast cancer, and the self-efficacy, and these barriers, using the health belief models. We utilize these models to assess these practices. For all the constructs, the health belief model, the higher the scores, half and above, were indicated as having high perception toward disperforming breast self-examination, except for barriers to breast self-examinations, in which higher score indicating high barriers to perform the breast self-examination. And the knowledge was also measured, and we used around 40 questions and 8 knowledge questions respectively. The other is practice were determined from the binary outcome variable. We asked yes and no using the questions. Have you ever examined your breast by your hand in the last 1 year? And those who responded yes were further asked appropriate time to perform the breast self-examinations, and the ways they are of performing is how frequently they did. These were asked. We utilized Epidata Manager for data entry, and also the Spaces version 21 for the data analysis. And we utilized the multivariable logistic regressions and the 95% confidence interval and the p-value of less than 0.05 were utilized to declare the statistical significance. And we checked the model fitness using the Hesmore and the Lomsham show goodness of fit tests, and the result of the model prediction and the overall p-value were around 81%. And the multicollinearity were also checked with the level of tolerance at 0.2. Here, when we see these results, it shows that the number of women who practiced ever is around 34.3% only. Those are ever practiced. So this finding is also similar to this cross-sectional study conducted among Egyptian women in 2013 and the Nigerian female teachers 2014, which revealed around 35.3% of Egyptian women and 36.2% of Nigerian female teachers had ever practiced breast self-examination. This shows that it is really still, this practice is very low in Africa, in different countries of Africa. When we look at the knowledge and the perception level, we see the ever heard of breast self-examination practice is only 51%. And regarding the knowledge, those knowledgeable is only 38.5%. Majority is still not knowledgeable. More than 61% is not knowledgeable about these issues. So this result is lower than the cross-sectional study conducted among female teachers in Nigeria, where 46% in 2012, and Mosul City among school teachers around 84% in 2013, among health professionals in Western Ethiopia, also 58%, and 77% in these populations are health professionals, so that they have some know-hows better than, still they are not 100% knowledgeable about these issues. Perceived confidence to perform is the high perceived confidence is 43.5%, and the perceived barriers is still those who have high perceived barrier is we can see it is more than 68% here, and the motivation to practice is still there are low perceived motivation is around 20%. This needs still adequate awareness. The other thing is why we asked the reasons for not practicing breast self-examinations. Most commonest reason is that they don't know how to do. That is awareness, and they have not adequate knowledge to practice, and the practice needs a good knowledge, so they don't know. And the other thing is they perceived as they don't have any breast problem, so they don't need that. That is among the reason. So the other thing is, the third one is they don't believe that it is beneficial. So all this needs adequate awareness creation. The result of the multivariable logistic regression shows that among the commonest factors, those are affecting breast self-examination practice is marital status. So single mothers are not practicing, and so married are around 4 times more likely to practice breast self-examination practice. And there is no difference, no statistical significant difference between single and the widowed or divorced or any separated one. And the other thing is being ever heard of breast self-examination practice is also more likely those. So even hearing awareness is very important, and even those who heard about this has about more than twice more likely when we compare with the others. Being knowledgeable is as well is also positive factors. It is around 2.85 more likely to practice than those compared to those not knowledgeable. When we look at the high perceived variable, those who have low perceived barriers has 2.62 times more likely to compare to the barriers still affecting to practice the breast self-examination practice. The other thing is perceived confidence. This high perceived confidence has also around 3.63 more likely to practice, and the perceived motivation is also very important. These are the factors we explored in this study, and so those are greatly affecting breast self-examination practice. In general, less than third of the participants ever practice breast self-examination, with only about 30% of them practicing regularly. The main reasons mentioned for not practicing were not knowing how to perform breast self-examination, and forgetfulness are the most common reasons. Being knowledgeable in breast self-examination practice, ever heard about breast self-examination practice, and being married and having less perceived barrier, high perceived confidence, and the motivation to practice were significant predictors of breast self-examination practice among secondary school teachers. And so on the way forward, our recommendation, we recommend that integrated work on behavior change, communication, and interference focus on improving the knowledge of breast self-examinations, skill on how to perform breast self-examinations, and identify domains of health belief model through training, continuous health education at the school, and through media to disseminate information regarding this. Breast self-examination may be the most effective strategies that should be considered by zonal health and education offices, including other non-governmental organizations working on health, and these health-related issues are among our main focus areas we recommend in the future. And so our sample population is really considered as literate parts of the population, but still the breast self-examination practice is very low, and that is all what we're found. In short, thank you. If you have any questions, comments, or suggestions, you are welcome.
Thank you, Dr.
Cancer progression and drug resistance. So this is like a cumulative research that I started back in 2015 on research, TRC funded research, or the Council of Research in Oman. So what I will start by giving you a brief introduction about the idea of neuropilin-1. What is neuropilin-1? So basically, if we always think about breast cancer, we have not to ignore that we have a cycle in order to know what are those biomarkers that they can help us in diagnosis. And that is actually, we always say bench to bed. That is true. So basically, when we start on cell culture findings, we can again later on try them on animals, and from the animals goes to the patients, and therefore again we also go from patients to the cell culture. So that is a cycle. It's not really bench to bed, but I would say it's also kind of bed to bench, because it's it's a cycle that we always need to follow when we think about cancer research. So what I do translational cancer research, and in this project or this presentation will focus on locally advanced breast cancer. When we talk about locally advanced breast cancer, we actually mean those cancers that they are existing in the breast tissue, and they did not metastasize to other organs in the body. They can be metastasized to the nodes, that's fine, but when we mean by locally advanced breast cancer, we just mean about those cancers that they just stay in the brain or the surrounding nodes. So It is known as, you can also call it as an inflammatory breast carcinoma. So locally advanced breast cancer, or the tumors of locally advanced breast cancer, are featured by biomarkers, and they are always in practice looking for different subtypes. We have even more than these, but these are the very commonly used ones. Luminal A, which is basically the tumor will be ER positive, progesterone positive, but HER2 negative. And these are the hormonal status that will be always tested on any tissue of a tumor or a breast tumor. We have also the proliferation factor Ki67, whether it's high or low, and therefore we are having luminal E, luminal A, luminal B-like, depending on the presence or absence of these hormones. And we have also the triple negative, and that is the subtype which is hard to actually treat usually. And HER2 type and luminal A, I would say, and anything that has a positive hormone, we also have hormonal therapy for their treatment. So it's nice to know the profile of breast tumors. Now, in terms of the management of the locally advanced breast cancer, there is many different ways. Definitely, patients will be started on chemotherapy to reduce the size of the tumor, so that the surgery will become easier. Surgery is following the chemotherapy, and then the radiotherapy and hormone therapy whenever it's possible, and there is like a positive for hormones. So therefore, we have like a big team who are working on breast cancer, starting from the radiologist and screening and oncologist, physician, surgeon, pathologist, and secondary physician if it's needed as well. So there is a big team on looking at the patients with breast cancer. So the chemotherapy that breast cancer or locally advanced breast cancer will receive, nowadays it's a regimen that is following like administration of alkylating agents such as like cyclophosphamide, adromycin, or doxorubicin with 5-fluorouracil or without. And then these will be like for 4 cycles, 20 days apart. And then they will be followed by a taxane, usually like paclitaxel or docetaxel, again for another 4 cycles, and therefore the patients will be ready if their tumors is shrinked to go to surgery. However, we noticed like the response to neoadjuvant chemotherapy varies among patients. So some patients are very well accepting the chemotherapy, and they will be they will achieve pathological complete response. And some of them, they actually, if the tumor is catched at a really early stage, they won't even go to the surgery because the tumor will be just diminished. When we talk, and there is no lymph node obviously involved. When we talk about pathological partial responders, those are the ones that they have a stubborn kind of tumor cells, and again, it will have like a small like residual tumors still in place. And we also have the third group where they are not responders at all, so that the chemotherapy with all the cycles for a long time, they didn't even reduce the size of the tumor, and in some cases it actually grows big. So the question comes here, why we have all these different variations? And basically, again, in terms of the level of the patient, again, it's either the patient will be in remission after the chemotherapy, and that is something we always like to see. So that is the absence of cancer in laboratory tests, physical examination, all the different examinations that the patient will be carried on, that, okay, after the treatment, after the surgery, there is nothing. So we call the patients at that time, they are in remission. So relapsed patients, those are the ones that were in this group, like either partially responders or non-responders at all. And these ones are when the cancer comes back again. So relapse is defined as the recurrence of cancer evidenced by all the clinical tests mentioned before. So therefore, we have now the era of omics, where we start talking about precision medicine. And in precision medicine, that means we have to involve not only the team for diagnosis, but now a team for diagnosis at a molecular level, where we talk about genes and genomics and RNA and transcriptomics. like proteomics, all these omics, they have been developed, and the technology is there to actually target each individual on what is his or her genes look like and what they are actually telling after treatment and so on. So from all this, we wanted to reach out for a single biomarker for each individual so that we can tailor the drug for that group in particular. So why neuropilin-1? Well, neuropilin-1 is one protein that came up after like so many of these studies that I have done like in the past. And then I noticed that this neuropilin-1 is a protein, although it's not a tyrosine kinase or anything, it's a co-receptor. But in fact, it actually plays a big role for the last maybe 3 decades now, that it's involved in carcinogenesis in more progression status. So therefore, it was my focus from almost the year 2006 when I was doing a postdoc at that time, where I actually knocked down this particular receptor, which is a tyrosine kinase, in ovarian cancer cells. Basically, I noticed that once this is removed from the cells using the RNA technology, RNAi technology, neuropilin-1 was upregulated. So I blamed that the cells became more tumorigenic in the absence of this protein. It's because of this protein. So since then, I wanted to know the function of this protein, and I wanted, or I hypothesized that it can be probably a predictive or prognostic biomarker, not only for ovarian, but also for breast cancer. And the reason it's because it has been like published, and we have noticed that it's also found in different types of solid tumors. Now, these are the different growth factors or different receptors that in neuropilin-1 kind of acts with. So, for example, TGF-beta, if neuropilin-1 binds to it, it actually activates the phosphosmad pathway and so on. VEGF, it binds to VEGFR2, and like downstream signaling for angiogenesis happens and so on. So it has different binding partners. So this protein is present in so many different cells. It has lots of different functions. Initially, it was found to bind to semaphorin in the nervous system, and later on in endothelial cells, and later on was found on immune cells, cancer cells. So we wanted to understand its function in cancer cells. And therefore, the first study we did, we started again from the bedside, where we collected blood samples from about 50 patients, normal patients with no morbidities, no disease, and also 50 patients with breast cancer, with locally advanced breast cancer. So basically what we did was we took the blood samples from the patients. We used histopac as a media. We centrifuged the blood and we isolated it into the different parts. So the plasma, for example, we measured the soluble neuropilin-1 in the plasma, and we noticed that between normal and the breast cancer patients, we didn't see any significant differences in terms of the amount of the circulating neuropilin-1 in the plasma. However, when we actually looked into grouping the patients and looked at also certain patients that they had metastasis versus the ones that they didn't have metastasis, we found that neuropilin-1 levels is slightly and significantly higher in that group with metastasis 1, but or lower concentration in no metastasis versus the control cells, or patients, I mean. Now we move on to the tissue. So we collected also biopsies and tissue after the tumor resection, and we did like tissue analysis for neuropilin-1 there. As you see, it's like a membranous cytoplasmic protein. And after looking at all these 50 patients, we noticed that in all patients that they had no metastasis. Again, as I mentioned to you, basically we work on no metastatic ones, but in fact, once we noted that there is no significant difference between locally advanced versus the control cells, so we focused on looking at some metastatic tumors as well. So M1 versus M0, you see that those ones who didn't survive or patients who didn't survive, in fact, I had a Kaplan-Meier, but I think I forgot maybe to put it here. They actually had much more, and the neuropilin-1 expression was still higher in their tissue. And also we took the PBMCs or the immune cells from the buffy coat, and we also quantified using real-time PCR neuropilin-1 and other proteins as well. And in control versus breast cancer patients, in that sense here, unlike what we have noticed, you know, in the other, experiment where we didn't see on the soluble level any differences, on this side here, yes, we found that PBMCs, they express actually less amount in terms of neuropilin-1 compared to the control. And that can be due to many different factors. We have to remember that in breast cancer, maybe in terms of immunity, this protein is going to do something else in the cells, and that is a little bit which needs a bit more investigation. So the conclusion was first that the plasma neuropilin-1 might be a good prognostic biomarker for metastasis, but rather not between, you know, breast cancer and normal cancer, or normal patients, I mean samples. Now, this result was actually, it's a longer kind of cross-sectional study, but it's showing basically that neuropilin-1 is associated with other molecules such as PLGF, VEGFR3, and other molecules in the blood, so that it seems, and we were able to tell that it is actually a prognostic marker for breast cancer in these clinical samples. When we move on to another study where we actually took some samples from patients who already received neoadjuvant chemotherapy versus the ones they didn't, and also compared it to the control. Like the statistical analysis shows here that, or the t-test shows the differences between before and after treatment compared to the control. We can tell that now the plasma level of neuropilin-1, in fact, after the treatment or after post-neoadjuvant chemotherapy, there was an increase in the amount of neuropilin-1. When we are also looking at in terms of response, we see that the ones or the patients who has more plasma neuropilin-1, they were the ones with which still actually didn't completely respond to treatment. So basically here what we say is that this is an indicator, or it's a predictive marker to show us that this protein is still high, similar to the fact that we saw that it also was very high in those patients who didn't survive you know, the disease. So basically this high expression of neuropilin-1 is associated with response, which is a bad response, which is again partially responder. So again, from this study, we completed before and after on the tissue level, and we looked into the Kaplan-Meier. Here, as you see, patients who actually had higher neuropilin-1, or they actually didn't make it, and the survival was less than those that had low amount of neuropilin-1. So we had it done as well in terms of, this is the survival. As you see, the mean concentration of neuropilin-1 was less in terms of blood, again in the survived patients, but increased in the died ones. So that's basically reflecting the same thing, which want to say that the higher the protein is, the less the survival of the patients. So that is a post-treatment, and that is a dead case, for example, and you can see that the expression of this protein is much higher compared to the pre-treatment. So this one who actually survived, the protein went down, and this one who didn't survive, the protein stayed the same in terms of tissue. So in order to validate these let's say, side data, we also ran in vitro validation. And in the in vitro validation, we actually took a cell line, which represents usually the triple negative breast cancer MDA MB231 cells. And we measured in the conditioned media the amount of neuropilin-1 when we actually treat after treatment, before treatment, and we see like after treatment, the amount of this protein is actually upregulated and it's higher. When we do like Western blotting, you can see that the protein also here, this is a saturated like blot of the same one. And you see like when we treat and more treatment, in fact, it actually leads to higher expression. That means it is kind of related to resistance to chemotherapy, because these cells, they were actually treated for several cycles of AC and PAC, modeling what we actually have in clinics. So therefore, this protein, not only that it's a predictive marker, but also it seems to be correlated with resistance. So neuropilin-1, we decided now in terms of loss and gain of function, we decided to actually knock down this gene. So once we knock it down, you can see there is no protein in this clone here. And we wanted to compare. So this is when you see clone 15, this is the knockdown. And we had different amount of protein. So this is a reduced amount, but this is completely gone. When we compare in terms of CFA or colony formation assay, you see that in MDA control cells, we have enough colonies. Once we actually, no treatment, but we have no neuropilin-1, the level of proliferation is actually reduced compared to the control. And then once we remove it totally in the control cells, we see that neuropilin-1 knockdown in control 15, and that is not treated again. Because of the loss of the protein, we have less colonies, which indicates that neuropilin-1 is really needed for the cancer cells to proceed. Now, when we take a look at the adrenomycin cyclophosphamide treated cells, what we see is that it's really proportional. So here is a lot of neuropilin-1, which is here in this red color. It has still the ability to form colonies. However, once we treat it with adrenomycin cyclophosphamide, because it has less neuropilin-1, again, the number of colonies is much less compared to the ones with treatment, but they are control cells. And then when we actually do knock down totally or knock out totally the gene, we see that once we treat the cells, they just produce very few amount of colonies. And in the ones that they are treated with paclitaxel, and these cells, by the way, they were also treated with adrenomycin cyclophosphamide. So this is like the last of the treatment. What we see that in MDA control, I don't want to talk about the resistance, because we have another graph for resistance. Here we are talking about the loss of the gene. So basically, if you concentrate with me, this is MDA control treated with paclitaxel, knocked down in small quantity, and that is paclitaxel treated. And then that is the one where we don't have the protein almost, and now you can see that we don't have any colonies. That means when we knock down the gene totally, then we don't have any colonies to be formed. And therefore, now we can tell that the presence of this protein is correlated with more progression and more proliferation. Once we knock it down, we make the cells kind of to become more fragile to the treatment, and the number of colonies formed are much smaller. So the conclusion is that neuropilin-1 might be a potential predictive biomarker after treatment, so for breast cancer in respond to chemotherapy. And that is also a paper where we published it in Frontiers in Oncology. Now we continued our journey with this protein, and now we are just going to talk about resistance. So basically, we took the cells, MDA and B231 cells, and also the MCF7 cells. Both of them, they were treated exactly as the patient treated in the clinic for different cycles. So they were like treated for 3 days, let's say, with AC. Now, all the cells, most of the cells died, but a few remaining resistant cells, they were there. We treated them again, another cycle and another cycle, and we were like collecting RNA and protein and keeping some of the cells at different passages in the laboratory to use them as, different time points of the treatment to see what is their genetic makeup and what is the protein makeup. So we come here to talk about the resistant MDA cells. As you see, after so many cycles in MDA, We checked all the pathway of resistance as well as survival pathways. For example, as you see, the first one here is neuropilin-1. In those cells, for example, treated only with 4-XAC cycles of 4-XAC. When I say 4-XAC, that means 4 cycles of AC. And then we have 4 cycles of AC and PAG. You see the protein is doubled almost from the control. So that means the treatment is actually making these cells to produce more protein, and the protein is actually supporting the growth of these resistant cells. So from there, we also checked some proteins that they are related to resistance. For example, BCRP, which is one of ABC pumps. We see that there is no need for them, and now other proteins are taking over for confirming or for conferring the resistance. We have the tumor necrosis factor also was decreased, and other pathways such as the phosphoinositol kinase, it's increasing in terms of resistance. While if we take a look at AKT, in fact, phospho-AKT, at site 473, we see that, especially on the very resistant cells, it's actually decreased. And we learned that the decrease happens because of upregulation in the P10. So P10 usually is the one to activate or deactivate phospho-AKT. So in addition to that, we also looked at the other adhesion molecules, because we hypothesized that also adhesion of the cells might be affected. So integrin beta-3, as you see, it's going with resistance, so it increases with more resistant cells, which is again correlated with focal adhesion kinase, phospho-NF-kappa B, which is the inflammatory cytokine, or I would say transcription factor or related transcription factor. It's increasing in those resistant cells. In addition, we know that, for example, the tumor suppressor ecadherin in MDA cells is completely missing, and that is true. So it was missing and it didn't get back again when the cells became more resistant to treatment. And therefore, we checked also the downstream molecules, which are related to EMT or epithelium to mesenchymal transition pathway. And we found that vitamin 10 is actually increasing in the very resistant cells. ZEB1 is increasing. And then the cells, they usually don't form spheroids or they make it very loose. The resistant ones, they actually couldn't really make these solid ones. So basically, because they lost these, I would say, adhesion molecules such as vitamin 10 and ZEB1. So in the other cell line, which is the other model, which is MCF7 resistance to treatment, it's on the opposite. Remember in the previous slide, I showed you that the neuropilin-1, for example, here increased. However, in MCF7 here, it was decreased. The same proteins were tested, and it's a completely different pattern. Again, this is referred because MCF7 belongs to the luminal A subtype, and it's not triple negative. So therefore, we can expect that the profile of proteins in the resistant cells will also be different. The way that also produced like these, I would say, spheroids or small spheroids, they were really different between the resistant or the resistance to 4-XAC and resistance to 4-XAC, 4-X paclitaxel. So that you see there is really differences between the treated cells or not. Now, when it comes to, we wanted to double check on the the subtype for each one of these cells, we noticed something very interesting in the neoadjuvant chemotherapy treated cells. It seems that it actually changed the subtype of the cells after treatment. And that is interesting because MCF7, it's very well known to be a luminal A, which means only ER is positive, which is this one here. Now, ER is positive, yeah, but at the same time, we noticed that phosphorylation of HER2 was upregulated in these resistant cells. So the treatment or the neoadjuvant chemotherapy actually changed the subtype of this cell line to become a HER2 positive, ER positive. So that it was really striking, and we really wanted to know what's going on and why MCF7 turned to be like that, which is a feature, by the way, seen in many cases in on a clinical setting. Whenever a patient is receiving the treatment, their breast tumors, they change their subtype, and therefore nowadays, like for this resistant cells, they actually will benefit if they are going to take trastuzumab because of the expression or overexpression of HER2. So we actually looked at single time point treatment, and we noticed the same thing. Although these are not resistant and these are just treated for 2 hours, 4 hours, until 48 hours, we noticed that it seems that the treatment is kind of, you know, when we talk about the promoters and we say constitutive promoter or inducible promoter, it can be induced. That is exactly the scenario here. It seems that the cyclophosphamide, adriamycin, or paclitaxel, they are actually inducing the neuropilin-1 as a reflection right away from the cell. It actually produces neuropilin-1 kind of to combat damages that happens because these are damaging to the DNA. So anyway, we don't know exactly still yet why it's that happening, but we noticed not only that in neuropilin-1, but we also found it on HER2. So the same pattern of neuropilin-1 is in HER2. That's why we said here the subtype is completely changed, because HER2 is also positive. Interestingly, also phospho-HER2 was also upregulated in the last time point, which is at 48 hours. It didn't get upregulated here, but in fact, in terms of phosphorylation, it seems that yes, all these drugs, and notably on paclitaxel, the paclitaxel really upregulated the phosphorylated form of HER2 from the 2 hours of treatment. And we also looked at if there is any kind of regulation on the epigenetic level. So we checked HDAC 4, HDAC3, DNMT, DNA methyltransferases, and histone deacetylases. And we noticed that, yeah, there is kind of an evidence that when HDAC is high, and then we have some DNMTs are getting down, so maybe these enzymes are kind of regulating the amount of these proteins, trying to explain why the treatment is actually increasing the amount of HER2 and neuropilin-1. So we suggested to look at the correlation between these two proteins, neuropilin-1 and HER2, if there is any communication between them, if the cells are making them at the same time, and so on. So we noticed here, like in HER2, we actually performed HER2 immunoprecipitation on the MCF7 treated for 24 hours, and also in MDA, because we know that MDA has a lot of neuropilin-1. So we pulled the protein using HER2 immunoprecipitation, and then we blotted the first day with the neuropilin-1, and that is the result. We found that once you pull HER2 alone, you will be detecting neuropilin-1. We suggested here that actually the neuropilin-1, and this is the second day blot where we see that neuropilin-1 and HER2 are present in the same sample of immunoprecipitation. And this is like an image also to show the differences in all these cells. So the conclusion was that neuropilin-1 might be a potential diagnostic and drug target biomarker for refractory breast cancer because it actually happens in more I would say progressed tumors. And this kind of result was published in the British Journal of Pharmacology in 2020, where we give it the title Modeling Neoadjuvant Chemotherapy Resistance in Vitro, Increased Neuropilin-1 HER2 Expression and Converted MCF7 Breast Cancer Subtype. From there, we said, okay, now we knocked down the protein, we made a resistance model. Let's see what happens if we actually take the gene and we put it inside the cells and we overexpress neuropilin-1 in a cell line that doesn't have it. So basically, we took the cell line, which is known as BT474. We compared it with MDA and MCF7, and you see, like in BT474, the levels of neuropilin-1, the baseline levels, they are low. And from there, we decided to actually transform these cells with a plasmid that contains a neuropilin-1 gene. So we cloned the gene, and it's expressed. And now you see in BT474 neuropilin-1, there is a protein, while we have also a vector control control and the cell line. So we overexpressed the protein in the cell line. And now this cell line looks, as you see, it just made a strange kind of spheroids in the cell culture, which is completely different from the controls in the BT474. It's good to note that the BT474, it belongs to the luminal B or triple positive cell line. So it has all the hormonal status, and usually it's kind of a slow growing cell line. However, once we pushed neuropilin-1 inside, it actually started to grow faster. Oops, sorry. So we also did a pathway analysis for all the different proteins to be able to see what happened after we overexpress neuropilin-1. Interestingly, integrin beta-3, which is an adhesion protein, it's an integral protein there, was also upregulated. And in one of my previous kind of research, I noticed that integrin beta-3 in particular, not only my study, the previous study, but also other studies, noticed that once the cells contain or have integrin beta-3, they are very capable of metastasizing to the brain. And that was published a long time ago. So interestingly, so these cells that they overexpressed neuropilin-1, they actually overexpressed integrin beta-3. However, they decreased, for example, phosphoinositol kinase. They increased phospho-AKT. So it's a completely different pattern. And when we look at phospho-FAC, it's the same. It kind of decreases if we use also. This is a different story now. I think what happened is actually we took these cells and we sent the RNA of these cells that overexpress neuropilin-1 for transcriptome analysis. From the transcriptome analysis, we noticed that the tenascin C is another protein which seems to be very highly expressed in the same cells that we overexpressed neuropilin-1 in them. And therefore, we took TNC or tenascin C, and we kind of knock it down temporarily using the siRNA. And we noticed that, again, the neuropilin-1 is kind of, is also affected. Sorry. Yeah, in this picture, I can show you. So here in these photographs of the immunofluorescence staining, once we have, these are the BT cells, and these are the BT with neuropilin-1. So neuropilin-1 is here. We kind of course, took the average of the fluorescence intensity of the red color, which represents the protein neuropilin-1. We did also dual staining with tenascin C. And therefore, once we actually compared, we see that both proteins are actually present together. So that is also an evidence that not only HER2 is binding to neuropilin-1, but maybe we also have tenascin C in these cells. And basically, this is what we see here, is that neuropilin-1 is with siRNA of tenascin C is also decreased compared to the control. So we were able to kind of draw this kind of pathway where we talk about the neuropilin-1 overexpression, which led to an increase in TNFR, decrease in BCRP or the pumps for drug resistance. They stopped also the mature adherent. They increased the focal adhesion kinase and FKB and the tenascin C and vimentin, which are in connection with focal adhesion kinase. By this, we were also again able to tell that the more neuropilin-1, also the cells will activate all these signaling pathways in the downstream of it. So we published this again in the journal of BMC Cancer. So where we said neuropilin-1 promotes the oncogenic tenascin C integrin beta-3 pathway, which modulates chemo resistance in breast cancer cells. So we also did perform a CRISPR-Cas9 knockout of neuropilin-1 now, which is the opposite, so loss and gain of function. So we spoke about the gain of function. Now let's talk about the loss of function. So neuropilin-1 CRISPR knockout was done, and we studied again on the transcriptomic level what happened to the cells that they lost totally the the neuropilin-1. Again, downstream signaling was opposite of what we found in the upregulation in BT474. Remember, integrin beta-3 was upregulated there, but here is actually downregulated. So it goes with no neuropilin-1. So upregulation of neuropilin-1 increases integrin, but however, downregulation of neuropilin-1 downregulates integrin beta-3, downregulates P10, and so on. There are several different proteins that they were like these plots. They were quantified and they were repeated many times to show the reciprocal of what we see in the model of overexpression. So that is the knockout. We also thought to take tenascin C as well here, as we have seen it upregulated in the BT474. And now when we knocked down the neuropilin-1, you can see that also tenascin C went down. And hopefully you are with me in terms of HER2, the same. So this is, again, proves that HER2 and neuropilin-1 and tenascin C, they are proteins that they seem to be always together. This is a merged image of, the cells stained with neuropilin-1 and HER2. So you see the co-localization of the two proteins. And when we knock down, there is no protein, there is no HER2, there is no neuropilin-1. So that means in the knockout, also HER2 was knocked out with the neuropilin-1. And that is very, very serious. It's interesting if we are going to design any kind of drugs for such disease. So we have to consider neuropilin-1 in terms of diagnosis and quantification, because these two proteins are actually working together. That is an extra kind of studies to confirm again the connection between the two proteins. So this is immunoprecipitation, where we immunoprecipitate usually with the large protein HER2, and then we detect with the neuropilin-1. You see here we don't have any neuropilin-1, and therefore we pulled down HER2. Sorry. So when we did HER2, like to check if it's there or not, in the knockout, yes, we do have HER2. Not only that, we actually, because, we pulled with HER2. So on the knockout, there is no neuropilin-1 because neuropilin-1 was, downregulated, or we actually knock it out. And then we extended our immunoprecipitation results, where we did integrin beta-3. And it seems that also integrin beta-3 is downregulated in the knockout. So the intensity of the band here is much less. And once we did flow cytometry for studying like apoptotic events, what you see here is that we actually have also a clone where we rescued a neuropilin-1, but we weren't able to rescue it all. About 10% of the protein came back to the cells. And if you take a look at when we grow the cells just before, without FBS or without a growth factor presence, you see that the knockout cells, they are becoming much more sensitive to this event. So knockout cells have more, 7.5% or 6.4% of early and late apoptotic. We have like a 3.4 or 3.6% of late or necrotic cells. So yes, the reduction of the protein again makes the cells so sensitive to treatment, and they can die faster. So from there, we went into now the animal. So if you remember my first slide when I said from animal to bed, from bed to animal, now you see that, for instance, the tumor growth with a neuropilin-1 or the other ones, although there was a delay, but still, like with a knockout, the tumor cells, they still grow. However, when we looked into these photonic images, you see that the tumors, they were not able to actually metastasize to the lungs. So all these lesions that you see here, these are just the cells transferred from the primary site. It's an orthotopic kind of model that thanks to Prof. Peter Greer for doing this in his lab. He was able to help us doing this in his lab at Queen's University. So we got like a neuropilin-1 knockout, no lung metastasis. However, the rescued with 10% also we still have some. So we concluded that neuropilin-1 knockout actually leads to reduction in metastasis. We tried to understand that by doing the transcriptomic analysis, and we found that neuropilin-1 knockdown or knockout actually has a completely different pattern from the controls. As you see, upregulated genes versus downregulated is kind of opposite of the control. And we look at the KEGG analysis, we see that usually the metabolic pathways and the ECM receptor interaction and focal adhesion is the most to be altered. And that brings you back again to remember the connection between PI3 kinase, AKT pathway, and also when we talk about focal adhesion kinase and integrin beta 3. So yes, there is a connection between these pathways, which again still proves that the function of neuropilin-1 is to confer resistance, to confer more progression, and more kind of a prediction marker. And these are the different real-time PCR proteins that we validated to see that they are increasing in the knockout versus the control and the rescued. To that extent, we actually published this data recently in 2023, talking about neuropilin-1 knockout and rescue confirms its role to promote metastasis in MDA breast cancer cells. So once we knock it down, it prevents the cells from metastasizing to the lungs. And to this, I would like to thank all the team that helped in these different work. My PhD, the former PhD student, Dr. Noura, and former postdoc in my lab at VT, and Prof. Greer, and Dr. Yan from the Queen's University at Canada. And of course, we would love always to thank the funder and all the team, the clinicians that they helped in also collecting the samples. Dr. Charles Bakhit, who helped in statistics and the calculations and using SPSS. I would like to thank you all for listening, and I hope you enjoyed my talk. And the floor is yours to ask questions.
One meta-analysis. So my personal presentation, I am a radiology technologist with a master in radiation technology in health sciences from the Nuclear and Energy Research Institute. Today I work as radiology technician at the clinical hospital at the State University of Campinas and teacher of the technical radiology course at Senac Campinas in Brazil. So, the cancer that's most affects women in the world is breast cancer. Currently, with public policies such as annual breast cancer screening with mammography exams, the disease has been diagnosed early, which reduces morbidity through the cancer and allows for less mutilating treatment for women. Today, a third of breast cancers are diagnosed when they are still impalpable, which allows conservative surgery to be performed. There is removal of only the tumor with a negative safety margin for the disease, preserving as much of the breast as possible. As they are impalpable lesions, it is necessary to use a marker to guide the tumor removal process in the surgery. The first markers used in the world was metallic wire, a procedure known as wire-guided localization, the WGL. But today, there are radioactive options for the same purpose, such as radioactive seed localization, or CL, which uses the iodine radioactive seed, the seed of brachytherapy, as a marker. In our cases, the wire or the seed, the marker is implanted in the breast before surgery with the help of image exams such as mammography and removed during surgery along the excised piece. In the seed case, it is a radioactive marker, it is necessary to use a gamma probe detector during surgery for excising. To define the best technology to be used and support managers' incorporation decisions, it is important to provide a systematic and robust assessment that synthesizes the scientific evidence available. So, in this report, the methodology used was based in the acronym PICO. So population, intervention, comparators, and outcomes. The population uses women over 18 years old, diagnosed with a non-palpable breast lesions with for surgical intervention. And the technology evaluations main technology was the seed localization and comparator with wire localization. The results evaluated and the outcomes were efficiency, safety, and organization of service. So here there are databases used to select primary studies that provide the data for this report. Basically, stretch for randomizing clinical trials and cohort studies. And here is the search strategy used, initially in PubMed, and they updated for the other databases, respecting the vocabulary and of each one. So MASH terms use the breast cancer, breast surgery, and radioactive surgery, radioactive seeds. So the studies with returned in the databases were analyzed for selection or exclusion in 2 stages. For this process, Mendeley reference manager was used. In the first stage, the studies were analyzed by abstracts. In the second stage, the article was read in full to confirm its eligibility or exclusion. So the select studies in second stage went through a data extraction form to collect data on general information, methodology, evaluating outcomes, and results of each one. So the collecting data in the extraction form were synthesized by the outcomes of the meta-analysis. The random effect model was used with a 95% confidential interval, calculating the relative risk according to the number of events, yes or no, for the outcomes. For data in which meta-analysis was not possible, qualitative synthesis with narrative description was performed. So the selected studies were also evaluating regarding the risk of bias in research, each according to the specific tool for the type study. So, for an example, Robin 2 for used for randomizing controlled trials, and Robin's 1 for cohort studies. The evidence by the scientists in meta-analysis was also evaluating according to the grade 2, according to the parameters, methodological quality, inconsistencies, imprecision, indirect evidence, and publication bias. So in the results, the research, 40 primary studies met the PICO eligibility criteria and were selected. 3 economic evaluation, 18 randomized clinical trials, and 23 cohort studies, 25 retrospective and 80 prospective studies. The synthesis of our studies totaled a population of 90,182 women, aged between 20 to 92 years old, and it also included in patients undergo localization in bracting, that is when use 2 or more seed or 2 or more wire, and patients who undergo neoadjuvant chemotherapy were also included too. So about the outcome of efficiency is important in the breast conserving surgery is the surgery is completed with negative surgical margins to cancer. So the breast can be free of cells cancer to reduce the rates of reoperation and the risk of disease recurrence. In the meta-analysis, the seed localization showed lower rates of positive surgical margins, lower rates to reoperation, and the disease recurrence, all with smaller volumes excited during surgery. Furthermore, the procedure of sentinel lymph node biopsy can be performed concurrently with seed localization without interference or failure of either method. About safety, the marker-related complication rates or rates of postoperative complications such as lymphedema, infection, or displacement of marker were equivalent between the two technologies, to the seed and to the wire, but the seed localization patients reported fewer cases of severe pain, what is so good. So the patients in the postoperative questionnaire reported few cases of severe pain when compared to wire cases. So about logistic and organization of services, the duration of localization procedure and surgery time too were equivalent between the two technologies. However, the seed localization is still out regarding the time interval between the day of localization and day of surgery, because the marker is a radioactive seed, and the iodine is the physical half-life of 2 months. So the patients can be, the interval in the two procedures can be up to 2 months. So in the WGL case, it's not possible because after the implants, the surgery must take place on the same day, because the risk of displacement and infection one time of the wire projects out of the patient's skin, and the seed is comparator is millimetric 4 millimeters and applied directly on the lesion, on the tumor. Furthermore, the delays in the operation room is way shorter with seed cases than with wire cases. About the cost of materials, the calculation is similar between seed and wire. However, in the long term, there is a significant gain with seed per case, because they increase the flexibility of schedule and reduce the delays in the operation room, because the implantation and surgery don't all be made on the same day, or in case of seed and no in the wire. And for patients, it is no bad way to months, is the surgery. This is especially useful for patients who undergo neoadjuvant chemotherapy. One time, the seed is applied before the chemotherapy, and the seed continues to mark the tumor locally, even if the completion regression of chemotherapy for the other treatments the patient is making after. So concluding, the seed localization is a superior method to WGL in terms of surgical efficiency, obtaining results equivalent to wire in terms of safety, and presenting promising results about the organization of services, because the flexibility on the schedules and the patients who undergo neoadjuvant chemotherapy, and the markers can be made before the chemotherapy. So here the reference to published works relating to this research. I would like to thank everyone for the presence and the attention. And I would like to thank the organization committee for the invitation. Excuse me for the language, in Brazilian language. So I hope they will understand me and they contributing to these workshops. Thank you.
For today is serum levels of oxidative stress marker malondialdehyde in breast cancer patient in relation to pathohistological factors, estrogen receptors, menopausal status, and age. Can you see my presentation?
Yes, doctor.
Okay, thank you. As you can see from the title, the aim of our study was to determine levels of malondialdehyde as a well-established oxidative stress marker in breast cancer patients, and to compare it between malignant breast disease and benign breast disease. Few words of breast cancer. As we all know, breast cancer is the most common cancer in women, accounting for 25% of all female cancers worldwide. And most of the risk factors for breast cancer development and progression are to some extent implicated with reactive species generation, according to Halliwell from 2007 and Penny G from 2009. According to nowadays researches and results from studies, the consequences of carcinoma cell oxidative stress showed that oxidative stress is connected to cancer development. Accelerated tumor progression due to reactive species mediated inactivation of additional tumor suppressor genes within tumor cells and increase in expression of photo-oncogenes. Then we have activation of growth promoting signaling pathways due to reactive species mediated promotion of cell proliferation in vitro, increasing blood supply to tumor cells, and consequently increasing risk of metastasis. On the other hand, malondialdehyde is well-established oxidative stress biomarker derived from lipid peroxidation process from 2001. In this study, during this study, we determined the serum levels of malondialdehyde in patients with invasive breast cancer in relation to its serum levels in patients with benign breast cancer disease. We also investigated correlation between malondialdehyde serum levels with pathohistological prognostic factors such as tumor size, lymph node involvement, histological grade, estrogen receptor status, and with breast cancer patients' age and menopausal status. Our study was prospective case control study. Involved were 43 breast cancer patients. From those, 27 were with positive axillary lymph nodes, and 16 with negative axillary lymph nodes. 39 patients were with benign breast disease. Tumors were classified according to the criteria of the World Health Organization. Histological grade was obtained in accordance with the modified Scarp-Bloom-Richardson histological grading system. And the staging was based on TNM system, tumor node metastasis system. Determination from malondialdehyde in serum of breast cancer and benign breast disease patients was performed by fluorimetric methods, and sample and standard preparation was performed using Okava's modified Yagi's method. Yagi's method was established in 1998. These results were evaluated by Mann-Whitney statistical test for independent samples, and correlation we have used Spearman's correlation factor. For all performed tests, we used P smaller than 0.05, and we consider it as statistically significant. For statistical analysis, we used SPSS 17 software. According to our founded results, the most important that we found was statistically significant difference in malondialdehyde serum levels in patients between patients with breast cancer and those with benign breast disease. So we can here see that Mann-Whitney test was used. P grade was 0.042, and those with breast cancer had a higher level, mean this significant value from malondialdehyde in nanomoles per milliliter. Other differences were not statistically significant, but as we can see in table 2, we found that malondialdehyde serum levels in patients with lymph node metastasis have had higher levels from malondialdehyde in serum instead of patients without metastasis, but there was no statistically significant difference. When we compared the malondialdehyde serum levels in breast cancer patients with positive and negative estrogen receptor status, we found lower MDA levels by the patients with negative breast cancer patients with positive breast cancer patients. Also without statistical significance. In table 4, we show that we analyzed malondialdehyde serum levels in breast cancer patients regarding menopausal status, and we found that the higher level from MDA levels were by patients with postmenopausal status and lower by perimenopausal status. And when we look about the age, those patients with higher age, with more age, have lower status of MDA in serum as they are in postmenopausal status. So we found to the statistically significant correlation between serum malondialdehyde levels and ages of breast cancer patients with positive axillary lymph nodes according to Spearman rho factor with P 0.006. And molecular mechanisms that relate oxidative stress and estrogen receptors signaling are very complex and include other molecules such as interleukin, vascular endothelial growth factor, interleukin 6, or other processes such as inflammation. The further investigation of breast cancer biology from the overview of oxidative stress may be helpful in the understanding of breast cancer etiology and obtained to our results from our study. We support the importance of malondialdehyde in the carcinogenesis of breast cancer, although according to our findings, serum level of malondialdehyde could not be useful prognostic factor in breast cancer. We need further researches to establish these facts. So thank you for your attention.
Thank you, Doctor. Now the forum is open for discussion.
Next slide, please. And if you see the mortality, it ranks 6th. Next slide. And this incidence and the mortality is gradually increasing day by day. And if you see the trends, if you see from the 2020 to 2040, both the incidence and mortality of the female breast cancer is going to increase. Next. So the rationale behind this study is the reactivation of hepatitis virus has potentially fatal complication, and there is lack of robust data of association of common chemotherapeutic agents and this virus reactivation. Many patients showed viral reactivation during the chemotherapy and targeted therapy as per the literature. However, there is a lack of guidelines of the viral energy or the DNA-RNA titer monitoring during the course of chemotherapy. Next. Hepatitis virus reactivation may occur with chemotherapy and is associated with significant morbidity and mortality. And increasingly, hepatitis B virus reactivation is described in patients with the solid tumors receiving chemotherapy, and that is particularly in the breast cancer patients receiving anthracycline-based regimen. The hepatitis B virus reactivation is also present in other commonly used chemotherapy regimens in solid tumors, especially in the breast cancer. Next, please. In most cases, reactivation occurs in patients who are the carriers of the hepatitis B virus infection, showing positive HBsAg, and hepatitis was defined as a threefold or the more increase in the serum alanine transferase that exceeded the upper limit of the references. Hepatitis attributable to hepatitis B virus reactivation was defined as an increase in B virus DNA level of 10-fold or more than the baseline level at any time during the chemotherapy and up to 6 months after completion of chemotherapy. Next. C virus reactivation has also been reported in patients with the solid tumors. However, it is less common than the B virus reactivation. C virus reactivation was similarly defined as at least threefold increase in serum alanine transferase level accompanied by reappearance or the sudden increase in the serum C virus RNA level. Patients with significant levels of B virus DNA in the serum prior to chemotherapy and patients receiving intensive chemotherapy for pregnancies are particularly at risk. Next, please. In this present study, we aim to determine the incidence predictors, and the clinical significance of hepatitis B virus or the C virus reactivation in patients receiving chemotherapy. Next. This study was a prospective observational study conducted in the Department of Medical Oncology in our institute, and the study was approved by the Institutional Ethics Committee, and there was no conflict of interest. Hepatitis B and the C virus status were identified before initiation of cancer chemotherapy, and during the course of chemotherapy, all patients were monitored for liver function before each cycle of the chemotherapy, and those patients which shows abnormal liver function test were subjected to repeat viral antigen test and the DNA RNA titer levels. Next, please. Predictors of reactivation like the performance status, nutritional status of the patient, menopausal status, receptor status, stage at presentation, chemotherapy agent, dose, and frequency were identified. And all patients who developed hepatitis due to B virus or the C virus reactivation were referred to and treated by hepatologist. Patients with the hepatitis virus reactivation were started with antiviral therapy along with supportive measures, and the chemotherapy was stopped. Once the liver function becomes normal, enzymes and the bilirubin becomes normal, the chemotherapy was resumed if the scheduled chemo was not completed. Next. In this pie diagram, you can see total, we observed 260 breast cancer patients who had some history of the hepatitis carriers. And among the 260 patients, 43 patients, approximately 17%, were identified with the hepatitis virus reactivation during the study period of 1 year. Next. If you see the chemotherapy regimens that was administered for the patients who showed the reactivation, maximum number of the patients received the taxanes, followed by the paclitaxel plus carboplatin. However, other agents were also involved in the reactivation, like the trastuzumab, capecitabine plus cyclophosphamide, trastuzumab plus taxanes, then capecitabine alone, doxorubicin plus cyclophosphamide, gemcitabine plus platinum, CDK4/6 inhibitor, and even one patient were receiving the trastuzumab intensive. Next. Further analysis shows that older age and the post-menopausal status patients were higher in the number. The performance status with one were higher in the number because these patients were the fit for receiving the chemotherapy. If you see the receptor status, either the hormone receptor positive and HER2 negative or the triple negative breast cancers were higher in the reactivation group. Next. Higher stage, especially the stage 3 and 4, were maximum in the number, and the patients who showed the reactivation received the multiple lines of the chemotherapy. Next. So coming to the discussion, reported rates of hepatitis B virus reactivation in B virus carriers who undergo chemotherapy range from 14 to 72% as per literature, and in the present study, we found that 17% patients showed the reactivation. C virus reactivation seems to be less common than the B virus reactivation. In our study, only 2 patients out of 43 were positive for the C virus. Patients with the cancer who are at risk of infection with the hepatitis B virus or the C virus should undergo standard viral screening before initiation of the cancer chemotherapy, and this is the institutional protocol. An increasing number of the cases have been described among patients with the solid tumors, among whom the highest rates of B virus reactivation have been reported for patients with the breast cancer, similar to the present study. Next. B virus reactivation has been reported mostly in patients who are tested positive for HBsAg. However, viral reactivation can also occur in previously infected patients whom the virus has apparently been cleared. Such patients can be identified by the presence of antibodies against hepatitis B core antigen, that is anti-HBC, or against HBsAg, that is anti-HBs. Patients with the B virus reactivation may be asymptomatic or having symptoms of hepatitis like fatigue, anorexia, jaundice, ascites, and coagulopathy. Reactivation can lead to the hepatic encephalopathy, liver failure, and death. In fact, in our study, 2 patients with the B virus reactivation died of the liver failure. Next, please. Next, please. Reactivation typically starts with an increase in viral reapplication caused by chemotherapy-induced immune suppression, and the increase in viral reapplication can be estimated by the rise of B virus DNA levels in the serum. This rise can precede an elevation of ALT levels. The risk of B virus reactivation is influenced by both the type of malignancy and the particular immunosuppressive therapy that is administered. Because the cause of reactivation is not known, but seems to be because of the immunosuppressor. The disruption of chemotherapy as a result of B virus reactivation can decrease overall survival, and the prophylaxis against B virus reactivation should be initiated as early as possible before the onset of immunosuppressive therapy in HBsAg positive patients. Next slide, please. Maximum number of patients with the viral reactivation in the present study were treated with taxanes, followed by taxane plus platinum chemotherapy. However, other agents like trastuzumab, capecitabine, doxorubicin, gemcitabine, CDK4/6 inhibitors were involved in B or C virus reactivation. Older age, that is a post-menopausal status, and the patients with the previous exposure of multiple lines of chemotherapy were at higher risk of hepatitis virus reactivation, and the treatment with antiviral agents can effectively prevent hepatitis B virus reactivation and should be initiated before cancer therapy and maintained during as well as for the 6 to 12 months after discontinuation of immunosuppressive therapy. Next slide, please. So to conclude, hepatitis virus reactivation in this study was mainly caused by the taxane-based chemotherapy regimen, and the patients with the prior exposure to multiple lines of the chemotherapy were at increased risk of reactivation, maybe because of the immunosuppression. As per the literature, in breast cancer, mostly reactivation was found with the anthracycline drugs. However, in the present study, we found taxane as a most common culprit. Next slide, please. So what are the treatment challenges if you find the reactivation? The first is the treatment break that may lead to the tumor progression and ultimately affect the clinical outcome. So because of the reactivation, we have to stop the scheduled chemotherapy and we have to provide the supportive treatment along with the antiviral therapy. So definitely there will be the treatment break. The second is the reactivation may require the dose modification or the change in chemotherapy regimen because of the altered liver function, rising bilirubin or the enzyme levels. We have to modify the dose in some patients. So that is also the challenge. The third is the management of the complications of the hepatitis like the severe jaundice or coagulopathy. So that is the most difficult part, and if not intervened at appropriate time, we may lose the patient. The fourth is because of this reactivation, there may be the long hospital stay and definitely the increased financial burden on the patients. And not at the least, the psychological aspects which plays the role because of the reactivation, there may be the fear of tumor progression or the death among the patients because the scheduled chemotherapy regimens is not going to administer. Next. So these are my references. Next slide, please. So thank you for the presence hearing. This is all about my study and a few aspects of the treatment challenges during the reactivation of B virus or the C virus in patients receiving chemotherapy. Thank you.
Thank you, Doctor. This was an excellent presentation. Hope our participants have enjoyed this.
Thank you.
Experiments are designed to examine the growth inhibitory susceptibility of parental triple negative breast cancer model. And the susceptibility has been tested by using some Chinese nutritional herbs that have been used extensively in traditional Chinese medicine. Additionally, I would like to share some experiments on the development of drug-resistant model from the parental TNBC cells. This model is called as DOX-resistant. That means the cells are resistant to the chemotherapeutic agent doxorubicin. And finally, I would like to summarize some of our future research directions that take advantage of the data collected from the previous studies. The progression of early stage breast cancer to advanced metastatic disease is major cause of mortality in women suffering from breast cancer. The American Cancer Society has estimated new cancer cases to be at 287,850 in 2023, and cancer-related deaths to be 43,250. The major treatment options for the triple-negative breast cancer include conventional and targeted therapy. The conventional therapy uses anthracycline, taxols, and platins as major cytotoxic chemotherapeutic compounds. In addition to that, the targeted therapy uses PARP inhibitors or polyadenosine ribose polymerase inhibitors. It's an enzyme inhibitor. And cyclin-dependent kinase inhibitor, which is another kinase inhibitor. Major limitations of conventional and targeted chemotherapy include systemic toxicity, drug resistance, and emergence of chemo-resistant cancer-initiating stem cell population. The cancer stem cells, which have been one of the main areas of our research, are subpopulation of chemo-resistant cancer-initiating stem cells, which show disruption of signaling pathways such as Wnt beta-catenin, hedgehog, and notch. The stem cells are also known to activate the signaling pathways of RAS, PI3 kinase, AKT, and mTOR, and also shows the activation of epithelial mesenchymal transition, which is the main cause of metastatic spread of the disease. Because of the limitations of conventional and targeted therapy, there are certain therapeutic options which have been considered. These include the effects of natural products such as dietary phytochemicals and nutritional herb formulations used in traditional Chinese medicine. Some of these natural products also have been shown to target stem cells, and their efficacy has been investigated for the natural products. In comparison with the limitations of targeted and conventional therapy, the advantages of natural compounds is mainly because of their documented human consumption, low systemic toxicity, and documented preclinical efficacy. This slide describes the main experimental models which we have developed and have been used in our research. The main cellular model for triple-negative breast cancer is the cell line which is called MDA-MB231. This cell line lacks the expression of estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2 or HER2, and is sensitive to cytotoxic effect of doxorubicin. Using this parental cell line, we have developed a resistant cell line that is called as MDA-MB231 DOX-R. DOX-R is abbreviation for doxorubicin resistance. The molecular status is pretty much similar to parental TNBC. That is, they lack the expression of estrogen receptor, progesterone receptor, and HER2 receptor. but shows cellular resistance to doxorubicin. And this is the model which we have used for isolating and characterizing drug-resistant stem cells. Now, the survey of literature has shown pretty extensive published evidence regarding the effects of bioactive natural compounds on triple-negative breast cancer. For example, natural compounds such as isothiocyanate, resveratrol, curcumin, EDCG, genistein, are known to affect multiple targets, which include apoptosis, induction of apoptosis, inhibition of PARC, AKT, and mTOR. While network pharmacology with prednisone has shown it also affects the activity of mitogen activated protein kinase or MAP kinase, inhibits this prednisone, a naturally occurring agent, inhibits this MAP kinase activity. In addition to phytochemicals, certain nutritional herbs have also been used in this on the triple-negative breast cancer. For example, the nutritional herb Cornus officinalis, Dipsacus asperagus, and Sorelia coryliflora have active bioactive agents such as anthocyanins, saponins, flavones, and terpenes. And we have shown previously that these nutritional herbs affect the signaling of RB, RAS, PI3 kinase, and AKT by inhibiting these signaling pathways. Of note here is that for the nutritional herbs, we have used non-fractionated aqueous extract to simulate the patient administration, which has been used for during traditional Chinese medicine. This slide, we have compared the growth characteristics of 184B5, it's a human mammary gland epithelial cell line, and the MDA-MB231, which is a cellular model for triple-negative breast cancer. We have compared the growth by following endpoints, which include population doubling time, saturation density, cell cycle progression, seen by the ratio between G1 and S2 plus G2M phase, that is quiescent phase versus proliferative phase, and anchor-independent colony formation, which is a sensitive and specific biomarker for tumor-derived or tumorigenic cells. As can be seen related to the non-tumorigenic 184B5 cells, the MDA-MB231 cells shows about 56% reduction in the population doubling time, about 39% increase in saturation density, and 67% decrease in G1 is to S plus G2M formation. These data reveal active hyperproliferation in the MDA-MB231 model and accelerated cell cycle progression. In addition to that, as I mentioned, the anchor-independent colony formation is not expressed in 184B5, but is highly expressed in MDA-MB231 cell line. In this experiment, we are looking at the effect of the three nutritional herbs, Sorella coryllifolia, Cornus officinalis, and Dipsacus asperagus. Here we are looking at the effect of these nutritional herbs on cyclin D1 formation compared to control. All the three, in response to treatment with all the three herbs, the cyclin D1 formation is inhibited. Here we are looking at cyclin dependence kinase 4 activity compared to these drugs. Of note here is that depending upon the endpoint in question, the rank ordering or the potency differs. So here the data has been organized based on the rank ordering of efficacy for each endpoint. In this slide, we are looking at cyclin-dependent kinase 4, CDK4 activity, and it's seen that compared to the control, in response to treatment with DA, CO, and PC, this activity is substantially decreased. We also looked at cyclin-dependent kinase 6 activity. It's another kinase activity which is plays an important role in RB signaling. Again, in response to treatment with DA, CO, and PC, this activity has been substantially decreased. In this particular model of TNBC, it has been documented that the regular signaling of RB is a tumor suppressor gene, retinoblastoma gene, and the activation of the signaling pathway is dependent on phosphorylation of RB. So here we are looking at so-called abnormal RB signaling in response to treatment with drugs PC, CO, and DA, the nutritional agents. And data here is expressed as the ratio between phosphorylated RB versus total RB. Phosphorylation is the main active step in the RB signaling pathway, and since the RB signaling is aberrantly effective in this particular triple negative breast cancer model, we are interested in looking at whether these nutritional agents can inhibit the phosphorylation or activation of the signaling pathway. And we have shown that in response to treatment with PC, CO, and DA, the ratio is increased because of the inhibition, ratio is decreased because of the inhibition of phosphorylation of RB. These compounds have also been tested for their ability to induce cellular apoptosis. And we have shown here that when we measure the population of sub-zero cells, which are the apoptotic cells, the cells which are in sub-zero phase of the cell cycle, we have shown that in response to treatment with DA, CO, and PC, there is increased population of apoptotic cells compared to the control. One of the biomarker for cellular apoptosis is caspase 3-7 activity, which is a pretty sensitive marker for cellular apoptosis. And in this experiment, we have measured caspase 3-7 activity in response to treatment with DA, CO, and PC. And as can be seen here, compared to control, this caspase 3-7 activity is increased in response to treatment with all the three nutritional herbs. One of the herbs which we have tested here is DA, or Dipsacus asperatus. And here we are looking at the ability of this drug to affect RAS signaling, PI3 kinase, and AKT signaling. Again, as I mentioned, as similar to phosphorylation activity of RB or any other protein, the phosphorylation activity is the hallmark for signaling pathway, activation of signaling pathway. So here we are looking at the ratio between phosphorylated over total protein. And here we are saying that compared to control, the cells treated with DA, or Dipsacus asperatus, the ratio between P-ERK and ERK is substantially decreased because of this treatment. This ERK signaling is a major constituent for the RAS signaling pathway. Similarly, the ratio between phosphorylated PI3 kinase and total PI3 kinase again is decreased because of inhibition of phosphorylation of this protein. Essentially, similar trend is seen with phosphorylation of AKT, and the ratio between phosphorylated AKT versus total AKT is again decreased in favor of phosphorylation. Now, moving forward with the isolation of drug-resistant stem cell model, we have used the parental MD-MB231, have exposed for a long period of time to cytotoxic or cytostatic dose of doxorubicin to select and isolate doxorubicin-resistant phenotype. Here we are looking at the cytotoxicity, difference of cytotoxicity of the DOX-sensitive phenotype versus DOX-resistant phenotype. We are measuring this by measuring the viable cell number in response to treatment with doxorubicin with the treatment to two different phenotypes, the sensitive and resistant. As that can be seen here, the doxorubicin-resistant phenotype shows progressive cell viability and growth in the presence of cytostatic doxorubicin, whereas the sensitive phenotype is substantially decreased in cell viability. In order to characterize the stem cell markers for the doxorubicin resistant model, we have used three stem cell specific biomarkers. One is the biological marker called the tumor spheroid formation, ability of cells to form tumor spheroids as non-adherent colonies in serum-free condition. Here we are looking at the tumor spheroid number in DOX-sensitive and DOX-resistant cell lines, and as compared to sensitive phenotype, the resistant phenotype shows substantial increase in the number of tumor spheroids. We have also used an immunofluorescence assay to measure the expression status of cell surface markers and transcription factors, which are specific for cancer stem cells. And in this assay, the cells are treated with relevant antibodies for against the cell surface proteins or transcription factors, and the cellular uptake of the antibody is monitored by fluorescence assisted cell cycle, and basically it is quantified by the number of antibody positive cells. Basically, the cells are separated out on the flow cytometer, showing these two peaks. This peak is negative for the antibody uptake and does not show any fluorescence, whereas the positive cells show the fluorescence because of the fluorescently labeled antibody. This immunofluorescence assay is basically consists of staining the cells with fluorescently labeled FITC labeled antibodies and staining of the control cells with FITC labeled IgG, which is a control cell. We monitor the cellular uptake of the antibodies by fluorescence-assisted cell sorting, normalize the experimental data by subtracting the control staining from the antibody-treated staining. The endpoint here is log mean fluorescent unit, RFU, per 10 to 4 fluorescent events. Here we are looking at the expression status of cell surface markers called CD44, transcription factor called NANOG, and another transcription factor called OCT4. And here we are comparing the DOX sensitive and DOX resistant cell lines. And as seen here, the resistant cell lines show increased expression of cell surface marker, which is specific for stem cells. This is CD44. And similar fashion, the same increase is seen in response to expression status of NANOG and OCT4, the two transcription factors. This slide just overviews the therapeutic option for triple-negative breast cancer. The chemotherapy includes the use of doxorubicin, carboplatin, paclitaxel, olaparib, and cyclin-dependent kinase inhibitors. These are basically used on ER/PR negative, HER2 non-amplified, that is the luminal A type of breast cancer, whereas and has been shown to affect cell cycle and induce apoptosis. Also, endpoint, as I've shown in the previous slides, RB, RAS, PI3 kinase, AKT, mTOR, and BAX are the endpoints which are quantitatively measured to look for the efficacy. As far as nutritional herbs and molecular targets, these are usually in the traditional Chinese medicine, there is multi-herbal formulation. We have shown the data from CO, PC, and DA, 3 nutritional herbs, and I've shown their effect on RB, cyclin D1, CDK4, CDK6, on RAS, PI3 kinase, AKT, and ratio between BCL2 and BAX, which essentially, in addition to caspase-3-7 activity, BCL2 versus BAX ratio also is a quantitative marker for cellular apoptosis. BCL2 is an anti-apoptotic protein, whereas BAX is a pro-apoptotic protein. So the variation between these two proteins shows the quantitation of cellular apoptosis. Again, as I mentioned earlier, the limitation for chemotherapy is systemic toxicity, drug resistance. Advantages of nutritional herbs are low toxicity and human consumption. So in conclusion, I would like to include that nutritional herbs show antiproliferative effects that are associated with inhibition of RAS, PI3 kinase, AKT, and RB signaling pathways. Pro-apoptotic effects are associated with increased sub-zero apoptotic cells and induction of caspase-3-7 activity. In the doxorubicin resistant model, treatment of parotid TNBC cells with doxorubicin is associated with selective growth of doxorubicin resistant or DOXR phenotype. And this DOXR phenotype exhibits upregulated expression of biological and molecular markers of stem cells. Based on these research directions, we have decided to go into future research, and this slide basically summarizes our future research directions. Basically, we are interested in examining whether bioactive components present in natural compounds can serve as drug candidates or putative drug candidates for therapeutic alternatives for triple-negative breast cancer. Basically, drug discovery methods are multi-step process, which includes isolation, extraction, or chemical synthesis of bioactive agents. Then high-throughput screening-based prioritization of bioactive lead compounds. Now, these lead compounds are further analyzed by genomic, transcriptomic, proteomic, and metabolomic assays, and also network pharmacologically used to look at mechanistic pathways and molecular targets identification. And finally, the promising lead compound can be used on patient-derived tumor assays for their anti-cancer activity. Now, future directions, we have decided to divide into 3 main objectives. One is the telomerase expression. This is a universal marker of cancer and therapy-resistant cancer stem cells, so that we can test selective inhibitors as telomerase inhibitors as therapeutic alternatives. Epigenetic modifiers are basically at physiological level, 1-carbon metabolism for methyl group donors is a major metabolic pathway which is relevant to epigenetic gene silencing, gene promoter methylation. So we would be interested to see whether these natural occurring bioactive agents can function as
Thank you, Dr. Nitin. Now the forum is open for discussion. If there are any...
Leon. The background of study, the mechanism of sodium glucose cotransporter 2 inhibitors is as follows. They modulates the sodium glucose cotransporter on the nephron, inhibiting glucose reuptake and allowing increased excretion of glucose in the urine, thus lowering the serum glucose levels. Around 12 years ago, I have published the review article on the sodium glucose transporters in the diabetes management. That time, the drug under phase 3 trials, all these medications like gliflozins. So that time, most of the research shown that it may cause a lot of acidosis and massive diuresis, urinary tract infections. But now it is the very important medication. So that's what we did. Again, the review of the sodium glucose transporters, what is the current status. So here these drugs are taken individually or in conjunction with the other glucose modulating drugs. The effects of SGLT2 inhibitors on glucose are heavily researched, showing significant benefits in maintaining optimal glucose homeostasis. SGLT2 inhibitors are being available for patients less than 1 decade. It is recently that scientists have assessed some of its long-term effects on the human body as a study for decades. The diabetes is known to lead harmful comorbidities and sequel of complications. Therefore, it is essential to assess the benefits and risks of glucose modulating drugs to ensure they do not exacerbate effects of diabetes and are more protective of organ systems than destructive. The methods This literature review examines the positive, negative impacts of SGLT2 inhibitors on cardiovascular system in the body. We examined scholarly articles from the Google Scholar and PubMed databases after 2017 that were relevant to SGLT2 inhibitors and any individual or combination of organs. We included randomized control trials, systematic reviews, meta-analysis, and traditional reviews. So here is some data about the various research. The first one, around 42 clinical trials with a total of 61,076 patients. The benefits identified, the SGLT2 inhibitors, the treatment was associated with the reduction in the incidence of myocardial infarction, cardiovascular mortality, and all-cause mortality. Basically, the SGLT2 inhibitors, by reducing the volume, they are beneficial if the patient having congestive cardiac failure and also hypertension. If the patient is taking on SGLT2 inhibitors, they can reduce the antihypertensive medication, and also it's a protective effect on the patients with diabetes and heart failure. But the risk, on the other hand, the risk of ischemic stroke was not reduced after SGLT2 inhibitors with the type 2 diabetes. Especially these are more significant benefits in the heart failure mortality. And another study, double-blind phase 3 trial, there are 1,549 patients aged above 18 years with type 2 diabetes, and HbA1c is around 7 to 10%. SGLT inhibitors added benefit lowering body weight and blood pressure, preserving the glomerular filtration rate, lower hypoglycemic adverse events when compared to glimepiride. The risk is the small increase in the baseline of hematocrit, total cholesterol, low density lipoprotein cholesterol. High density lipoprotein cholesterol levels were noted with empagliflozin compared with the glimepiride. There is another study, 33,124 participants taking SGLT2 inhibitors and 26,568 taking placebo compared to study. Here, SGLT2 inhibitors were observed with a reduced risk of infections of respiratory disorders and might be associated with the glucose-lowering efficacy of medication. But the risk is SGLT2 inhibitors were not significantly associated with the reduction of other 115 cardiovascular respiratory diseases. And another study with the small study with 93 patients with a heart failure, the gliflozin significantly reduced the pulmonary arterial diastolic pressure with effects that began at week 1 and amplified over time with the empagliflozin versus placebo. The results were consistent with the pulmonary arterial systolic and pulmonary arterial mean pressure, whereas the risk is empagliflozin can significantly increase the fractional sodium excretion, which persists for at least several weeks to reduce the blood volume and plasma volume. Conclusions. The collectively SGLT2 inhibitors lead to overall decrease in mortality and wide array of physiological processes that would add to these patients' longevity. These benefits include weight loss, liver enzymes, biomarkers improvements, optimal glucose homeostasis due to insulin and glucagon in the pancreas, less incidence of cardiopulmonary related and neurological diseases, cardioprotective effects, and reductions in the blood pressure. Some adverse risk in small proportion of individuals on SGLT2 inhibitors include volume depletion and hypotension, pancreatitis, and episodes of temporary hypoglycemia. While these risks are potentially harmful to the patient, they occur in less than 1% of cases, can be due to confounding variables and pre-existing patient health. In conclusion, SGLT2 inhibitors act primarily on nephron's proximal convoluted tubule. Through this literature review, we concluded that SGLT2 inhibitors are beneficial in most patients, especially those with renal dysfunction. and we are optimistic about the future evolution of this drug class. These are my references. Thank you for your patience. Thank you, everyone.
Thank you, Dr. Subha. This was an excellent presentation. Hope the participants have learned and benefited by sharing your research work.
Thank you. Thank you, everyone.